It's my great pleasure to introduce this session. There's a debate. I'm assuming it's going to be a very healthy debate between subpectoral and prepectoral, essentially. So you have just heard Mr. Peter Barry. He's a colleague in Royal Marsden. Peter, floor is yours.
Thanks, Amit. So I'd like to thank, again, the organisers for this very clever title, because it's about the placement of the implant under the pectoralis muscle is hardly ever necessary, rarely necessary. So I'm arguing that it's rarely necessary. And really, this maybe translates loosely into schiathos poter or spanios. I don't know what's the best term. But we're not saying never, we're just saying hardly ever. Now, I am like in a wolf's den here because, of course, Attica is the home of rhetoric and the logographos, these famous people, Antiphon, Demosthenes, and all these amazing speakers from ancient times. So I have no hope really with the debate, but I'm going to give it a go. So the first thing I'm going to ask you to think about the following considerations: safety, quality of life, and financial toxicity. And the first thing is oncological safety, but also surgical complications. And we'll be talking about all these issues. Quality of life, and I want to break that down into pain, aesthetics, and functional outcomes. And then finally, financial toxicity, the procedure cost. And I want you to think firstly about the mesh cost, but also the long-term costs. How many times do we have to bring this patient back for revisional surgery? And then also the economical but psychological costs for the patient. So what are the potential benefits of subpectoral? Because I'm sure my charming and knowledgeable adversary is going to talk about all these things, so let's get through them. So I'm sure that part of the issue is muscle covering the upper pole, and I know because we've all been there, subpectoral. Certainly it gave you good supply to the back of the neck, and the upper pole, good vascularization. You got a better décolleté, the takeoff, there was no step. And of course, it pretty well eliminated this issue that we now see with prepectoral rippling or wrinkling. And of course, it's a smaller ADM, and we've heard about the price of ADM per square meter, so the cost should be less. What about solutions then? Well, the first thing I would say is that the mastectomy is a standalone procedure. So the mastectomy needs to be done on its own merits. You do it according to the oncology, not according to the method of reconstruction. That's the first thing. Now, of course, you need to plan everything in advance together and integrate everything. But first, look at the extent of disease. And you may need to resect part of the pectoralis major muscle, so that's a very important question to ask. What about reduction of complications and this question of the vascularization? Well, you have to select the patient carefully. And in most patients, we might find that it's safe to eliminate the pectoralis raising. And it's a shared decision-making consent. We need to advise what are the pros of subpectoral and what are the cons and what are the pros and cons of prepectoral. Meticulous attention to surgical technique I've already spoken about, and so you can refer to my previous talk and the assistant, of course, and we've talked about post-operative care. Well, what about the aesthetics? Well, we can fix that problem, and someone kindly asked a question in the last session about the rippling, and it does get better with time, and it's much better with or less with radiotherapy. We'll talk about that in a moment. But you can put ADM there if there's no fat, or you can change the shape, put a new implant in essentially, or do fat grafting. And fat grafting, of course, is the common solution for both the takeoff and the rippling. Well, what about the costs? Well, can we consider no ADM at all? And that's a good question. So Cicero Urban just published this recently in the last couple of months from Brazil, and he looked at over 300 patients and another center, I think, from Argentina, without ADM, prepectoral, direct to implant. And the main risk factor for extrusion was smoking with a 4.33 odds ratio. And otherwise, the complications and outcomes were very comparable to series with ADMs and possibly even better. You can see here, neck necrosis, 1.4%. Grade 3/4 rippling, only under 4% in the long run. And this is follow-up over 6 months, remember, and it does get better with time. And your capsular contracture rate, which is going to be the big positive of prepectoral, of course, is much less. And we'll talk about muscle fibrosis shortly. So you heard I opt for anterior cover only. And I apologise if this is a bit sexist, but we'll move on. Okay, so we've talked about ADM, and we use selectively, and that's very important. So if a patient is a cup size A, B, low risk otherwise, we create a nice tight pocket, as in we make sure we don't go beyond the breast tissue, and then we'll put, if there's good pocket control with the sizer, we won't use an ADM. And we've had no real issues that I can really tell you about. What if things are looking bad, though, on the table? So there are two scenarios. You have a skin flap, you're worried about perfusion before you put the sizer or implant in. Well, what do? Well, I use adrenaline in my tumescence, so often things look like, they're dead already before I've started. So I would then wait, maybe by the time I get around to the implant, the bleeding starts again, use some warm packs, and then check for bleeding. Bipolar diathermy, of course, because this is the safest, I think. And if it happens, though, after the sizer is placed, I don't put an implant in, I put an expander, and I put air in the expander. And that's very important, I think, because it reduces the weight and stress on the skin envelope. So I can solve most problems with an expander empty or with a little bit of air, and then all the other techniques, negative pressure dressings, and the nitrate gel that I mentioned before. Well, I know that smoking is a big issue in Greece, and we have to think about those patients who've got poor tissue, and we all know it's the nicotine. It's not the tar, of course, that's another issue altogether, but the nicotine is a big issue with small vessel spasm, and we have a crazy problem in the UK and US, because, of course, the NHS recommends that you vape so that you don't smoke. So now everyone's vaping, and even school children, and there are probably people in this room with school children who are already vaping, and I have this conversation with my kids about why it's not good to vape. But this is the rate of vaping that's gone up, and it's high nicotine content, often higher. So one vape is often equivalent to one packet of cigarettes. This is how it's advertised for kids. It's a USB stick with different flavors and colors. I mean, what's more enticing to a child? You tell them, don't have a sugary drink, but let's have a vape instead. More fun. And this is from the US, where there's a real concern about children getting addicted to nicotine at a young age, and it's got all other effects, but we need to ask our patients about vaping because it's becoming more of a problem, and it's not going to reduce our problem with our mastectomy flaps, so it's really important. So they need to give up at least a few weeks before, ideally. Well, what about BMI, high BMI? Is this a problem for prepectoral? No, it's actually better in prepectoral because you've got thicker planes, thicker tissues, and it's more tolerant generally. So this is a study by Gabriel, who's very well known in the plastic surgical community in the States. And you can see that if you looked at dual plane versus prepectoral, this is unadjusted, stratified by these two factors, then all the complications, seroma, surgical site infection, capsular contracture, and all other complications were much higher in the dual plane group. But when they did multivariate analysis and adjusted for all the confounders, then dual plane still came out as highly significant as a risk factor for any complication versus prepectoral. So this is probably a good data set to look at. Now, there's a recent meta-analysis. It came out probably a few days ago from Annals of Surgical Oncology, and it's the group who are now leading the EU breast trial of prepectoral breast reconstruction. And what they looked at was 3,100 patients with 15 studies, and favouring prepectoral capsular contracture, significantly less, prosthetic failure, significantly less, and animation deformity, of course, which we haven't really touched on yet, significantly less. The rest were non-significant. And what's interesting is BreastQ, and this is one of the arguments for doing a randomized trial, is that BreastQ has never shown a benefit for prepectoral. And why is this so? And this has really irked me because I think patients should be happier. Of course, they can't compare, but why might it be so? Let's look at this. Well, all the studies use the minimum of this satisfaction with the breasts score. Have a look. How you look clothed, how your bras fit, can you wear clothing that's more fitted, unclothed? Which of these questions differentiates between subpectoral and prepectoral? None. It's a blunt tool. There's no validity. It's rubbish. And that's the only thing that every study used. Most of the studies didn't use this, which is really much more of the detail with satisfaction with breasts. Why not? Because this is only used if you have bilateral surgery. It's counterintuitive, and same with rippling. What about the well-being chest? Not done in any of the studies. So we really have no good comparators with BreastQ so far, and this is something hopefully will come. Well, there is one RCT can you believe it? In Denmark, I think you can do anything. They randomized patients pre-PEC versus sub-PEC in the operating theatre after the mastectomy. I mean, I take my hat off. They really have achieved the impossible. So they did this study, and interestingly, their primary endpoint was animation and secondary endpoint was pain. Okay? And no guesses for who wins here. So nipple sparing, skin sparing, they had quite tight exclusion criteria. So you can say, okay, it's maybe not very generalizable to many patients that we see, but, you know, obviously they did their best. And they did develop a very nice scoring system, I think, for animation, which looks at the animation around the neck and the top of the breast, the skin surrounding the neck, and then the entire breast, and they give each a score and then a total score from there. And this was published just recently again. Well, what did they show? At 12 months, 100% of subpectorals had bad, which is breast animation deformity, so it's bad, compared to 23% where it was mild in the prepectoral group and probably was rippling, in fact. But, you know, they looked for it, and the assessors were blinded, so they didn't know, and they got 23% of mild animation in the prepectoral group. But the majority were severe or bad in the subpectoral group, whereas the rest were in the mild one. So here's an example from their paper, which you can download, of what they would classify as severe animation. Oops. So what about pain? Well, this is a paper, and it's been shown in many other papers already prior to this one, but this is randomized, so I'll show you first, that in postoperative days 1, 2, and 3, there was a significant difference in pain levels by analgesia use and also visual analog score, favouring the prepectoral group. But by 3 months, there was no difference. And I think that reflects what we already know from other studies. What about opioid use? This is a big problem in the US. I don't know what you do here in Greece, but we try and avoid opiates in the UK for this sort of thing. But we know all the problems associated with opioids. And we know, and this is from Holland's group, again published this year. It was a prospective cohort study. Subpectoral had a higher opioid usage, you can see almost double. And in linear regression, subpectoral reconstruction was a significant contributor to postoperative opioid use after correcting for all the other variables. So, you know, that's a bad thing, and even if it's only for a few days, it's potentially harmful, potentially even in the long run. Well, what about radiation therapy? And this is where the benefits really stand out with prepectoral. So we know that radiotherapy is a problem. Wound infection is greater with all forms of reconstruction, but prepectoral too, no question. Increased wound infection, increased capsular contracture, about 5 times, and increased rate of implant loss. But what we do know, and again, this is quite a good study by Sinnott, one of the first people who realised that capsular contracture, especially after radiotherapy, is much less after prepectoral compared to subpectoral. So subpectoral, 52% versus 2.9%, this is with radiotherapy, whereas it's only 16% with prepectoral. And so you've got a much higher relative risk, 3 times, that subpectoral after radiotherapy compared to prepectoral. So that's another good reason to rarely do subpectoral. Now, what about the other plane? And I'm so pleased we had a session on ALCL earlier, because that brings me to the next point. If you're doing a capsulectomy on these patients after radiotherapy, what a joy it is to go on the pectoralis major muscle and not have to see the rib cage. Okay? No bleeding, no pain, day surgery. It's a breeze. Same thing with ALCL. You do a radical capsulectomy on the pec major, you're laughing. I haven't done one yet. I've done subpectoral ones. It's a nightmare. So the same issues apply. And let's have a look. This is subpectoral. Everything moves up because it retracts with the muscle, the implant's under the muscle. Yet this is what we can achieve. It's the other side here in this patient. This is prepectoral. Well, this is the Natrel website. Okay? And what they say on their website for patients is that not all candidates, because it requires tissue good enough, which is fair enough, there's a risk of visible rippling, but not all surgeons have the experience, and there is a learning curve, so I think that's important. Well, I tried to Google I thought we convert a lot of patients from sub to prepectoral. Why? Mainly animation, pain, other issues. I thought, what if we converted patients from prepectoral to subpectoral? Does this exist? And Google said, do you mean conversion of subpectoral to prepectoral? Because there were 504 results the other way. So clearly there's something going on if we're converting sub to prepectoral, but never the other way around. So finally, Chairman and ladies and gentlemen, if we are to evolve, and we know evolution, of course, we all will eventually evolve into females one day, but that's another discussion for tonight maybe. We need to evolve with reconstruction, submuscular, subpectoral to prepectoral. And this was the initial day of prepectoral. I certainly hope we don't go back to that again, but we have the techniques and the technology and the expertise now to achieve good results. And again, this is my patient. And this is the EU breast randomized trial, and I'm out of time. I think I've shown you what I wanted to show you. It's in the right anatomical plane. There's less invasive, destructive functional issues, quicker recovery, reduced pain, no animation, reduced capsular contracture after radiotherapy, and you can be selective with your mesh to save some money. So replace it in the same space and ask patients what they want when they understand the pros and cons of each. Thank you.
Thank you, Peter. We'll go straight to the next speaker.
So the next speaker is Andreas Gravanis, and he's a consultant breast and plastic surgeon and the head of Department of Plastic Surgery at the Metropolitan Hospital in Athens here. So we heard from Peter why is prepectoral good and why subpectoral is bad, and we're going to hear the other way around now from Andreas. Thank you.
Andreas will start with some -2 point for being on home ground.
I will definitely defend the subpectoral reconstruction as well. Πιστεύω είναι θέμα connection. Να βάλω το δικό μου. Να βάλω το δικό μου. Sorry for the delay.
If we're waiting for the setup of the computer, does anybody have questions for Peter? We can take questions in the meantime. Anybody have any questions for Peter? Maybe Andreas will be able also to address those questions, give him some insight before he gives a talk, while we're waiting for the computer to be set up. Please.
About long-term pain after retropectoral positioning and ending up in the need to change levels. Thank you.
That's great. So Peter will answer this, and then we'll go to the talk for Andreas.
Time that would be very unfair. I think there's a mix of indications. I think animation is one, but yes, a lot of patients do have pain, especially after radiotherapy. Yeah.
Andreas, the next 15 minutes are all yours.
So-
Thank you.
As I said, I really enjoyed Mr. Barry's talk, but at the statement, the placement of an implant under the pectoralis muscle is hardly ever necessary. I have to answer no, and I will answer no with confidence. Despite the big revolution of plastic surgery and the big progress, we still follow the basic plastic surgery principles as they were stated by Sir Harold Gillis. And one of the main principles is replace defect with similar tissue, the like with like principle. So, the perfect replacement of the missing tissue should be a perforator flap that provides reconstruction with soft, pliable, vascularized tissue associated with minor donor-site morbidity. So we have to identify the ideal implant replacement. Among the various types of implants available today, each surgeon has his own preferences, and on the other hand, regarding the skin envelope elasticity following the mastectomy is definitely poor. That's why traditionally the implant-based reconstructions were performed subpectoral with the placement of an implant under the muscle, and in the recent years the lower pole of the breast is reinforced with the use of a mesh. Going back to the basic plastic surgery principles, another main principle is honor that which is normal and return it to normal position. So in that sense, the prepectoral position is the normal position that is practically the space that is left behind the mastectomy. The volume of the space depends on the dimensions of the chest wall along with the elasticity and quality of the skin that dictates the degree to which it can safely accommodate the implant coverage. So in recent years, there is a big enthusiasm about direct-to-implant prepectoral breast reconstruction, and that one was the study that was published in 2020, presenting the largest series of patients at that time. And as an answer to this paper in PRS, we published with Mr. Venizelos our approach in prepectoral breast reconstruction with a combination of lightweight implants and a collagen suit. Always in our reconstructions preoperatively, we do volumetric analysis, volume and weight estimates by the use of a 3D dimensional photoscanner. It is a Vextra XT by Canfield, but also intraoperatively with a very simple method of the elevation of the water saline. We have a rough estimation of the volume of the mastectomy specimen, and we have constantly found that for a given volume, the weight of the mastectomy specimen is approximately 20% less. So the perfect implant replacement for the missing breast tissue should be a lightweight implant that weighs as much as 30% less than traditional silicone implants, consequently have the potential to significantly reduce breast tissue stretching. And nowadays we have available the B-Light implants by Polytech. Regarding the loss of skin elasticity, there are multiple matrices used nowadays, both biologic and synthetic, but the most used one and most evaluated one and most published one is the Braxton mesh. We have the IBAC study published by Jose Macia, the largest multi-center data collection of prepectoral breast reconstruction. The elastic ADM fixed on the muscle could compensate the skin elasticity loss, and we hypothesized that by wrapping around a lightweight implant, this will result in a biological lightweight implant. The fixation of the ADM implant complex on the top of the muscle reduces the skin envelope compression during the critical healing period, and once the incorporation process of the ADM is complete, the engineered skin envelope presents enhanced elasticity to sustain implants' gravitation forces in the long-term basis. So we had a favorable experience and outcomes with this method. So in a prospective study of 36 patients, we had no animation deformity recorded in this series. We had no shoulder dysfunction, minor healing problems, and only one unplanned readmission within 3 months, and only one unplanned reoperation within 3 months due to skin necrosis that was managed successfully with debridement, and we changed the plane from pre-pec to subpectoral with the same mesh, and the patient healed uneventfully without to lose the implant in the reconstruction. So we concluded in this study that this combination of lightweight implants and the Braxton mesh adds a new dimension of prepectoral breast reconstruction. The use of biological lightweight implant respects breast mechanics and is promising for long-lasting results. Nevertheless, rippling is an adverse effect associated with this technique, and patients should be very carefully informed preoperatively. So this is a patient with bilateral mastectomies, 2 months postoperatively with prepectoral reconstruction with a combination of Braxton and lightweight implants. And this is the appearance of the patient 10 months postoperatively, and the rippling starts to be obvious. Rippling generally is a late aesthetic complication. Remarkably, it has been reported only 3.3% in the Braxton's IBAC study. And the joint consensus is that the acceptable rate should be less than 10%, but this is actually not our experience. Another patient with bilateral mastectomy and prepectoral reconstruction, 2 months postoperatively. The same patients, 6 months postoperatively, and the rippling is already obvious there. The same patients, 10 months postoperatively. Rippling based on strict criteria was noted over 40% in our reconstructions. So the patient 1 year post-reconstruction on your left side and your right side, 1 year post-lipofilling that successfully managed the rippling. And actually I saw recently the patient that is 3 years down the line, and rippling is very less nowadays. Prepectoral direct-to-implant breast reconstruction actually is not the evolution, it's the oldest method that was reintroduced to overcome animation deformity and postoperative pain associated with subpectoral reconstruction. But actually, if we study the literature very carefully, I think that the benefits are not so well documented. I know that the audience is mainly breast surgeons, but thinking as a plastic surgeon and thinking as a cosmetic surgeon, back in 2000, subglandular and practically subfacial breast accommodation, it was a big trend. We had very big enthusiasm about this method. We thought that will result in more natural results, but the fact is that the following years, the patients came back with significant rippling and visibility of the implant. So worldwide, breast accommodation shifted to dual plane or to muscle splitting techniques that optimizes implant soft tissue relationships in a wide range of breast types. Also, as reconstructive, and my main interest is reconstructive microsurgery, in 2015 we described our method and we have published it, the dual plane DF flap inset with the flap lying simultaneously behind the pectoralis major muscle at the upper part of the reconstruction and in front of the pectoralis muscle at the lower part, resulting in a dual plane flap inset that we have proved that optimizes aesthetic outcome. So we use in breast augmentation cases that we have a healthy breast to cover the implant. We use dual plane in microsurgical reconstructions to cover the autologous soft pliable tissue. What is going to happen when we use an implant just under the thin mastectomized skin? Are all cases suitable for prepectoral reconstruction? Is this lady that was a candidate for bilateral mastectomies, that she had previous augmentation and presented to us with excessive rippling? I don't know if it's very obvious from this photo, candidate for prepectoral? My answer to her was no. So we proceeded with bilateral mastectomies and subpectoral reconstruction. Are these mastectomy flaps suitable for prepectoral? As we see in the SPY camera, at least immediately after the mastectomy, there are areas of the skin flap that are not well vascularized. Probably these skin flaps will improve later and had improved, but we are not safe to do prepectoral breast reconstruction in this case, I think. So our decision about subpectoral and prepectoral reconstruction should be based on patient characteristics, radiotherapy, if she's a heavy smoker, and as Mr. Barry said, in Greece we have problem with the smoking, should be based on breast characteristics, the ptosis of the breast, the degree of ptosis of the breast, and also about the estimation of the mastectomy specimen. As a general rule, if it's more than 500 grams or less than 500 grams, more the mastectomy specimen means that we have bigger skin envelope that will be more devascularized after the mastectomy. And also should be based on intraoperative findings to have a good viable flap. Always we evaluate preoperatively the skin thickness on mammograms, and always intraoperatively, mainly with clinical criteria and occasionally with real-time endocyanine green angiography and SPY camera. So my point of view is that we should do very careful patient selection for prepectoral versus subpectoral reconstruction. That's why we did a retrospective study to compare the two techniques and define the ideal patient selection. We have used only porcine-derived acellular dermal matrix, Braxton for prepectoral reconstructions, and native for subpectoral reconstructions to have directly comparable outcomes. Demographics, clinical characteristics, complication, and patient-reported outcomes were compared according to the BreastQ. So we classified all the patients according to the degree of ptosis that presented to us preoperatively. Of course, the prerequisite was that all the patients were candidates for both techniques according to the skin thickness. And the results show that the number of the breasts with preoperative ptosis was not statistically different between the two groups. The mean follow-up was 11 and 12 months respectively. The average mastectomy weight and the average implant size were directly comparable. So BreastQ demonstrated that the mean patient satisfaction was similar among the two groups in patients without ptosis. In patients with ptosis grade 1, satisfaction was significantly higher in subpectoral group, and this could be attributed mainly to the less rippling deformity. On the other hand, patients with grade 2 ptosis were more satisfied with prepectoral reconstruction, and this could be attributed to the more normal ptotic position that the prepectoral reconstruction finally settled. Regarding the revision rate, in this series of patients, 1 out of 4 patients required, asked, and proceeded for a lipofilling in the second stage, and maybe more from this series will request lipofilling in the future, and none so far in the subpectoral group of patients. So as a conclusion, based on patient satisfaction and revision rate, subpectoral, it is the proposed method for us for ptosis up to grade 1, and prepectoral, I will encourage the patients that they have, of course, no risk factors, adequate skin thickness, because we believe in our findings that produces better result for ptosis grade 2. For me, prepectoral versus subpectoral reconstruction, it is the battle between rippling deformity and animation deformity, and depends what is more dissatisfying for the patient finally, and it depends the lifestyle, if she's involved in sport activities, it depends on the clothing style, and of course in her preference. Because we have to think out of the box, it's very different to reconstruct a breast in a woman that is involved in sport activities, in a woman that lives in another European country or Central European country, that the breast is more covered during the year, and different to reconstruct the breast in a woman in Mediterranean, in a hotter country, that the breast is exposed the most time of the year, and rippling definitely can be very annoying for her. As I said, as a plastic surgeon and as a cosmetic surgeon, that breast augmentation is the most common operation in our practice. Breast augmentation, the last 10 years, accounts 95% for subpectoral or dual plane or muscle splitting, the technique that I use. Also, in our center in Metropolitan Hospital with our breast unit, almost 68% of reconstructions are subpectoral. So, yes, the placement of an implant under the muscle is still necessary in many cases. Thank you very much.
Thank you, Andreas. That's a great talk. So if we get Andreas and Peter to come and sit here and take some questions, Amit will start with the questions and I'll take the microphone around. So Peter and Andreas, do you want to come here?
Yes.
Right. Two great talks. I think Andreas took the topic by its head, really, because he's a plastic surgeon. So I think as breast surgeon, we were thinking he's going to talk about reconstruction only, but you have talked about augmentation, which is very clever.
Actually, the statistic about augmentation, under the muscle, is worldwide, the rate. Plastic surgeons are not doing anymore. Maybe in England it's quite different because the women that are seeking, the women that are seeking for breast augmentation, usually they have plenty of tissue and adequate thickness at the upper pole, but not in other countries. In our country, the woman that is coming for a breast augmentation has usually pinch test less than 2 centimeters. So it's very easy with the coming years because, unfortunately, if we want to be honest with ourselves and honest to our patients, implants in both cosmetic surgery and reconstructive surgery, they become worse and worse with time. It's not a lifetime aesthetic operation. It is not a lifetime reconstructive operation. For the cosmetic patient that puts in implants, if it does that in the age around 20, will have 5 operations in her lifetime. So imagine what will happen for the implant-based reconstruction under a thin mastectomy skin. Moreover, if it's irradiated. It's a different discussion, of course.
So before we open to the floor, Peter, do you agree? Because you've been nodding in agreement. So are you letting the floor to Andreas?
I've got a slight spasm. No, look, I agree. I can't disagree with everything you've said. But I think in the oncological context, we have to think about radiotherapy. That's not going to go away. That's getting more prevalent. The indications are expanding, and it's becoming a more serious issue. So in my practice, the most serious issues I see are, subpectoral post-radiotherapy, although we're seeing less of that. Prepectoral after radiotherapy, is reduced incidence, and when you have a case, it's not so bad. And I think hopefully we can change the natural history with lipofilling, but some of those will need autologous as well. And I agree about implants getting worse with longevity, and autologous gets better. That's very well known. Yeah, no question.
I think the implant operation is not an operation for once. It's not an operation for life. And we know that they'll need always revisions. And if we're talking about rippling, then fat might correct the rippling. And most of the time for the young patients, the implant might be a temporizing thing before they get the flap in the future. Who wants to take any questions from the floor? Anybody has any questions? So ladies first, we'll start with Cornelia.
Thank you very much. Thank you very much for these very, very interesting presentations. So thank you very much. I wanted your opinion about one thing. I think the problem with a prepectoral could be not the material of the ADM, but the texture. If we had an ADM that wouldn't look like a thick piece of paper, and instead it would look like a sponge, so you would have something like a sponge being about 1 centimeter or more, and this sponge could get thicker in the direction of the décolleté. So in this case, and in the ideal case, it would be even resorbable. And in the most ideal case, you could design it with a 3D printer, because there are some studies going on with 3D printers, resorbable implants. We had this in our webinar. But I mean, even if it wouldn't be resorbable, but if they could construct it like this, then perhaps you wouldn't have the rippling, because it looks better, and it's better anatomically. And I think you don't have the other effect, which you can't change with the subpectoral. When she plays tennis or... so I think this would be a way to go. I don't know if it is possible for the industry, but I want to hear your opinion, or if you have spoken to the industry about this.
Thank you for the question. Actually, the problem with the meshes is that the mesh should take well from the poorly vascularized mastectomy skin. This is the main problem. Probably the seroma is not just a reaction, probably is a poor take of the mesh. That's why results in fluids and seroma, probably. So if you increase the thickness of the mesh, the take of the mesh will be less good. This is a problem. So, I mean, it's plastic surgery. Sir Harold Gill said that it's the battle between beauty and blood supply. It's all matter of blood supply. What blood supply you have from the overlying tissue? That is a thin skin. But it has to take the resolvable. It has to take, you know. Should be vascularized the first weeks.
So may I also just...
It's a matter of research, actually.
I think the meshes are a temporary thing that will disappear in years' time, and they will not like it here, the companies. I think we can see that many people are starting to put implants with polyurethane without any mesh, and if you control the mesh well, then they fill it with fat. I don't think that a 1 or 2 millimeter mesh will give you that volume. But the new thing, like you mentioned, there's the 3D meshes. And Owen Ung in Australia, they have a 3D printable mesh that you don't put an implant. They put it on the chest wall and fill it with fat later. And he's going to talk about that in one of the webinars in the iBreast book in January. That will be, I think this is the new thing that will come, because it will become very much like a, like the vascular AAA, what you call it, grafts. Now you can have tailored grafts that they do the CT scan and they just send the tailored graft and then they get printed and the graft comes to the vascular surgeon, just sutures it there, or they put an EVAR. And that's what's going to happen in the future. Once they find the 3D mesh that you can print, then you can send the photos of the patient with a 3D picture, and then just they print the 3D graft for that to be filled. Yeah, it's still a long way away, but I think that will be the future. I don't know what's everybody's thoughts about that.
It will be the future, but we're not so close, I think.
There's clinical trials. So
Yeah.
they've done 6 patients in Australia, and they're doing more now. And there's another trial in Europe. I don't know where exactly.
I think, as Mr. Barry emphasized, radiation therapy, there are increasing indications that more and more patients are irradiated. So all these grafts actually don't have good experience with meshes in already irradiated breast, and I don't have good experience with lipofilling in an irradiated breast, and generally I don't have good experience with implant-based reconstruction in an irradiated breast. I don't remember every single one of my patients from my point of view, not from the patient's point of view, because the expectations are not the same in all patients, okay? So, but as a plastic surgeon, when we evaluate the breast, I'm never satisfied with the reconstruction.
That's another question about how to
evaluate the patient.
Yes. Is it the breast Q or is it something else? Another question? There was somebody else that, yeah, Michalis.
Thank you. This is actually a question for both of you. I wanted to ask whether if pre versus post pectoral reconstruction is a battle between animation deformity and rippling, what if you are able to ablate the medial and lateral pectoral nerve, which eliminates animation deformity?
Yeah, actually, I don't believe to that. One of my special interests is facial reanimation with microvascular functioning muscle. I have used in the past pectoralis muscle. It's not, you cannot eliminate all the nerves of the muscle. It's impossible. It's impossible. But you can eliminate the animation deformity, because animation deformity is the relation of the amount of the muscle on the top of the implant and the size of the implant. That's why you get generally less animation deformity with anatomically shaped implants, because it's less the pressure of the muscle on the top of the implant. And then is where you split the muscle. So if you use the whole muscle, a small part of mesh, then you will get more animation deformity. So what actually I'm doing, I calculate the D distance, I mean the maximum projection of the implant, and all this should be covered by the mesh. So only the upper part of the muscle is used to cover the implant, and you have chances to get less animation deformity because less muscle on the top of the implant. So if you have loose mesh to the lower pole and less muscle on the top, maybe you have less animation. But I don't believe in nerves. I think it's possible anatomically to do that.
There are publications that completely agree. It takes several procedures. It's very complicated. It's very difficult. And I think now there's a very good system for pre-pectoralizing the pocket after capsular contracture or animation and pain, which consists of, taking down the muscle. I mean, there are big series now in the States and in the UK. Take down the muscle, put it back to the origin, suture it back to the origin, fat fill the anterior envelope, and replace the implant, and a capsulectomy, of course. And it seems to work well. I was just going to say, with respect to the previous question, that if you have time, risk reduction patients with thin envelopes, we pre-fill them with fat exactly in that décolleté area that you talk about, 1 or even 2 runs with fat because you have the time, and it works beautifully. So when then you come to reconstruction, and I tend to do pre-pec for them, it really helps. So you do it in advance, but you have time there, so it's a luxury.
I would like also to make a comment that lipofilling prepectoral is a very demanding procedure. It's not easy at all to solve your problem without risking the shell of the implant. It's because you have very thin layer of tissue to lipofill, and actually it's quite demanding.
It's a good point, actually. I recall a story of Krishna Clough. He was doing just that with a lawyer, and she asked him, do you ever puncture the implant with the needle when you are doing this? And just as she said it, apparently a bit of gel started coming out of the skin. He said, it happens all the time. So on a serious note, though, what we are now doing, and it's a really good point, is we use a very small needle with air or CO2 or a bit of Hartmann's, and under ultrasound guidance now, we are doing it, visualizing it under ultrasound and opening that plane up between the capsule and the skin, and then putting fat in. And the first time you do it, we just lay a very little bit of fat. So I always tell patients, the first one is really just going to, plant the seed in the soil, and then the next round we're going to do much higher volume. But it's a really good point. It can be a risky procedure. Yeah.
I think we're about 20 minutes behind now, so we need to close the session. Amit, any final comments?
Well, I think what I'm finding a very common ground, especially in reconstructive surgery, if you don't do a good mastectomy, you can do whatever you like, it will fail. Do you both agree?
Yeah.
Okay.
There's
I
no
think
doubt
we'll
about it.
close on a kind of an agreement note. Thank you.